Welcome to the Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is SumoSunD's CEO, Dr. Joshua Liu. Today, we're joined by our excellent guest. We have Dr. Armando Bedoya, pulmonary critical care physician and Chief Analytics and Medical Information Officer at Duke University Health System. Dr. Bedoya, Armando, welcome to the show.
Thank you for having me. Pleasure.
It's absolutely a pleasure to have you on the show. You know, you've been instrumental in leading the ongoing analytics and informatics work at Duke. You've witnessed the transition, I believe, from paper charting to the EHR and are now at the forefront of the evolution with the EHR, integrating data-based workflows and AI and generative AI. And I'm really curious, you know, with your background deeply rooted in critical care, what initially drew you to medicine and pulmonary critical care in the first place?
First and foremost, you make me seem like I'm ancient and everything. The transition into the EHR and all. I actually still remember being a medical student at the Warren Alpert Medical School at Rhode Island Hospital and writing on paper charts and that transition time period. So I feel like I'm an ancient at this point. People point that out to me because all the young residents and interns medical students have no idea how it was in a paper chart world. And I'm probably going to be the last of the dinosaurs in that aspect. Medicine and internal medicine in general, I frankly loved the thinking part of it. I really loved the concept of trying to understand from a diagnostic standpoint. You know, you have all these little hints and breadcrumbs from a patient, from their history, their physical exam, all these things. And I loved trying to see if you could put them together and try to see, well, okay, what's going on here? The pulmonary critical care part actually came a lot later. I knew I wanted to do medicine from a very young age. And in full disclosure, you know, my parents were both doctors. And so that obviously had a strong influence in my life. But when I came from medical school into residency, I was still undifferentiated. I was a medicine resident trying to figure out what I wanted to do in my life. And pulmonary critical care dragged me more than anything because I love the critical care part. It's all physiology. You have people with cardiac problems, pulmonary problems with physiology that you're trying to understand and trying to figure out by tweaking things, either on a machine or a medication. And you still get to do the hardcore internal medicine stuff of trying to understand, okay, these are the breadcrumbs you're trying to understand about the patient. But there's a time crunch now. These are sick people. So you have to put that all together and try to do that in a relatively short period of time.
Yeah. The pressure of putting the breadcrumbs together, the puzzle, that's pressure makes diamonds. That's really awesome. It's a really cool analogy. I haven't heard that before, but it makes a lot of sense. I'm curious as well, you know, at some point, informatics and analytics came into the picture. So like, how did that happen?
Much later in my career, which I usually tell a lot of the people who are not tech at first in their life. So in full disclosure, in undergrad, I was a medical anthropology major. You know, like I was completely outside. I never did any computer science class. I could not even program Hello World, you know, in C++. I couldn't do any of that stuff. All the way in medical school, none of that. Residency, none of that. I was more interested in doing blood transplant, actually. Clinical research was where initially I went. And then I surreptitiously had a program director in fellowship for my pulmonary critical care fellow said, you know what, Armando, you seem to like some of these people who like information technology stuff. Why don't you, you know, the Veterans Health Administration has a course in this. It's like, you know, it's a 6-month modules kind of stuff. Why don't you take a look at it and see if you like it? And I did it. It was totally free for residents and house staff officers. And I really, really liked it. And so I found myself just diving in deep, meeting with our chief health information officer, doing what we call informational interviewing, just talking to a ton of people on the side, doing LinkedIn, Coursera courses of trying to understand, you know, how do you program? What's the information stack and all of that stuff. And that really slowly moved me into interesting projects with our innovation group around our sepsis program, working on actual projects to stand up some of our data assets that we have to our EHR vendor. And then I slowly transitioned, you know, when I got to get my real job and got to grow up and everything, our chief health information officer said, you know, you seem to really like this. You seem to do okay in this. You want a job? And so I basically then became the medical director of our analytics center, and it just kind of took off from there. So I did a hard left turn in fellowship from a guy who was bringing medical anthropology kind of stuff in undergrad all the way to now heavy into data and analytics and AI.
When you first got into data and analytics years ago, was there a certain use case or ideal future where you're like, oh my gosh, I could see us using data analytics to solve this specific problem at some point in the future? I'm so excited by that. And like, given where we are now with data and AI, how close are we to what you were hoping we could do when you first got into this?
I think it's in pockets. My vision when I see about data and AI, data is the engine that drives any of our AI technology. When you look at healthcare in general, so I'm going to put my medicine hat on. If I was, in a clinic and stuff, I see you maybe once every several months, every 3 months, every 6 months, maybe a year if you're doing really well, and I'm just kind of looking over and making sure you're okay. So in our experience in healthcare, we have very transactional experiences. Your experience, though, you as a person, is totally different outside in the world. And a lot of that information that exists out there is actually super useful for me as a clinician. What you do with your life. Are you healthy? Are you happy? How's your home life? How's your work life? Stress, all these other things, your food, your ability to travel, your home situation, your finance, all of this stuff affects a lot of my decisions as a physician. If I had access to any type of that aggregate data like you, I could change the way I think. And that to me was kind of the dream idea that I still have of, can I see you as not just a patient, but as a person? Because the person is really what affects how I make decisions in health. So there are pockets of that. I think depending on the disease course you have, the more touches we have with you, we have a better idea of the information. But I still think we have a ways to go to get kind of to that dream of being able to understand you as a person rather than just as a patient.
Today's episode is brought to you by Seamless MD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what Seamless MD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. Seamless MD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50 plus out-of-the-box care plans available today on Seamless MD. Go to www.seamless.md. That's www.seamless.md to learn more.
And I'm guessing that maybe depending on how much data you have in certain specialties or the problem you're trying to solve, there may be certain specialties right now where there's lower hanging fruit for you to solve with analytics and AI, clinically speaking. What stands out to you and the Duke group right now in terms of specific clinical areas or problems?
So we stood up an initiative recently called Cachet. It's a collaborative to advance clinical health equity. And it's really our way to internally look at our organization and say, are we delivering care across the population of patients that we have equitably? Are we really being able to deliver patient care to these populations that might be underserved or underrepresented? And classically, if you look at electronic health record data, we don't really have a lot of the data in the umbrella of social determinants of health. We have proxies, zip code's a huge one. Who your insurer is, that's a huge one too. But it's not just that. It's, do you have access to technology? Are you able to actually physically get to the appointments that we need you to be able to get to? Do you even have access to broadband? To me, that type of where we're trying to, so what we've done is we've augmented our enterprise data warehouse by incorporating data that doesn't classically exist in there. The area deprivation index, business data that exists. It's important that if you live near a place of worship, if you live near a park, you live near a liquor store or a place that sells tobacco products, those all have important effects to the way you are as a person and then in turn as a patient. So I think we've done a lot of work there, and we've tried to look at specific cases and diseases and say, hey, can we do better here? And that really requires us to look at data that doesn't exist, as well as partnering with our university and school of medicine colleagues, because they understand that world. They understand a lot of those data elements that I was never taught on in my clinical experience, in my clinical education.
Can I ask you, so I guess one of the challenges is, even if you could get all that data that you're hoping for and make just much better predictions around risks for the population, there may be still a gap in terms of, well, now that I've identified patients and I might even know what resources they need, can we even actually get them those resources? So, for example, if it's an issue around income, the health system probably can't afford to just give, more money to patients who need it. So do you still feel like maybe there's certain use cases where actually, if we can identify the risk better, we can at least close the gap, but maybe there's some places where it's still unclear if we can even just deliver on closing the gap?
I think that's very accurate. So to me, the first thing is we have to acknowledge and find out if there's a problem. That's the first part of this. And I don't believe, that we're going to be able to solve all these problems on our own, but we need to be able to partner with these community organizations. We need to be able to partner with our governments and our local county, city, state governments to be able to say, we're seeing a problem here. How do we partner with you? So we have a great research project right now using this framework, looking at diabetes patients and then partnering with a community-based organization to be able to provide food vouchers and see if that actually helps. We tell them what type of patient populations, the one we think are the ones that we should go after. They've got the resources to be able to actually be that arm to go out to these people and provide them these type of vouchers for food, and we're going to see if we can make an impact. I think that to me is an important part of how data from different areas can be combined with clinical. We find a problem, and then we got to be able to partner out to be able to look across that spectrum of experience, that spectrum of care.
And I guess to your point, if we can't even identify the problem or the folks who would most benefit, no one's going to be willing to deliver on closing the gap because they're like, well, Armando, we can't just give it to everyone. So unless you can identify folks in the first place, why should we do anything different? So at least you're kind of getting halfway there, but then you're right, you need the other partners to help get you all the way there with the end result for the patient.
Exactly.
So Armando, a little bit more broadly, AI obviously is such a hot topic today. So I'm curious to get your thoughts on what you believe might be low-hanging fruit, high ROI use cases for AI versus other use cases that are maybe overhyped today.
So I think AI particularly can help with a lot of administrative burden. I think is probably the biggest thing. I think most people would agree that that's probably one of our lowest hanging fruit. I'm going to date myself here, but when I was an intern and medical student and somebody asked, write the note and everything, 2 sentences, a little bit of this, maybe 3 lines, 4 lines, you're done. That doesn't exist anymore in our electronic health records. I think we all talk about Notebook. We talk about the amount of documentation. I get a patient in the intensive care unit that comes from another hospital for a 2-week stay trying to get our expertise. I'll get a stack that's big. How do I flip through 500 pages worth of documentation to be able to understand it? So to me, particularly some of these generative AI products that are coming out that can summarize things for me, that can help with transition documentation, that ambient technology that makes my documentative burden less, and then I can stick to the things that I know that what the patient wants from me, which is my brain, my thought process, my ability to think about what the problem is and how to help them get better. So I think that to me is the low-hanging fruit out there right now. And a lot of physicians want that. They want to be able to spend that time with their patients trying to understand what's going on, rather than sitting there and documenting, or sitting there and writing a letter, or sitting there and trying to read through 500 pages worth of documents.
How close do you think we are to being able to use some more of the generative stuff in actual clinical care safely? I totally get that the low-hanging fruit, the low-risk areas, let's do the administrative stuff that can't really hurt patients, that can be in a safer environment. But I feel like everyone keeps thinking that at some point, can it cross into direct clinical patient care? And because I think one of the unique things about healthcare is, because when people think about things like asynchronous, autonomous conversations between, let's say, a patient and an AI, we can see that working okay in other industries like travel and retail, where if the chatbot gets it wrong, it's okay. It's okay if you miss your flight, or if something's going to scheduled properly. But there's so much more risk. We're talking about direct clinical care. So maybe we're not quite at the chatbot phase for clinical care with the patient and autonomous kind of patient care. But what do you think might happen the next year or two clinically, at least, that could get us, I guess, closer to the future of where this could be?
I think probably if I think about a lot of the specialties that seem to know how to use augmentation of the AI technologies, radiology is a great example, right? Like there's lots of tools that exist out there. They may get a prioritized list and say, okay, this top image looks like it might have a pulmonary embolism, a blood clot to the lung. Okay, that one's going to be, because the AI, augmentation AI knows that, it's going to put that up to the list and set it over to them. Doctor can confirm, radiologist says, yep, that's a pulmonary embolism, that's a blood clot. Okay, I'm going to read this quickly and go on that side. I think those types of low-hanging fruit of where it can help you prioritize, it can help you nudge you in the appropriate workflow. I think that's where low-hanging fruit is. I think people, particularly clinicians, feel that there's still a lot left for us to say, well, can this autonomous thing make a decision on its own? And then I'm kind of reviewing it. I think that still, to this point, is not there yet. But I do see us making small inroads in augmentation, saying, hey, this is coming up here. Let me nudge you at this point and say, these are the reasons. I think transparency, particularly around those types of tools, this is the reason why you should think about this. I think keeping the human in the loop, particularly, I'm just even speaking from a patient standpoint, would be something that people would also want to make sure that those safety, those guardrails are there. If I think about devices in general, I'm going out to get a CT scan, MRI, a ventilator, things like that. They've gone through so much rigorous evaluation. There has been certification. There has been training manuals. There is a maintenance schedule that actually, you get, and you have to check in on it, and you have to do specific tests to make sure it works okay. So me as a clinician, I feel pretty comfortable when I order an MRI scan or a CT scan on a person, because I know it's gone through that processes. I may not know exactly 100%, what's happening in an MRI machine, but I know people around it have looked at it and verified and said, this has been certified. This actually makes sense. This thing's going to work within the parameters that it's supposed to. And I understand, at least from a diagnostics, what I'm looking for. I think that's where we need to get to with these types of tools before people feel incredibly comfortable. Now, how we do that with innovation in a rapidly moving space, that's a whole another topic.
I guess the other thing that comes to mind is, even if someone genuinely believes that we should and will get to a point where there is some level of autonomous AI, maybe for low acuity cases or something else, it does feel like having a human in the loop is the stepping stone or the path that's needed, because human in the loop will be able to actually help train the model to do it well, to do it accurately. And then over time, it's a question of, okay, has there been enough training by actual human clinicians that the model is good enough for certain use cases? But it feels like to even get there, the human has to be in the loop for both safety reasons, for training and otherwise. It's exciting to see what's going to happen the next couple of years. One of the things that you've mentioned in the past is that you've taken like a risk-based approach to thinking about AI. So for example, generative AI for operational functions that are further removed from the patient are low risk and be expedited. What's your philosophy or thinking about AI risk? Because we could say administrative is low risk, clinical care is high risk, but I know it's not that clean, and there's probably a spectrum. So how should folks think about assessing risk in AI right now?
I really do think that you have to think about how close to the patient you're talking about. It's hard to separate the world of administrative operations and clinic. It's not that clean, as you said. I agree with you entirely. If we create an AI tool that can predict how long the case is of a surgical patient, and then we're going to change the surgical blocks according to that AI technology, which means one patient may go in front of another one because it just makes the blocks easier, but it doesn't change the care. Where does that fall? Is that administrative operations? But then you might be getting a surgical case a few hours later, maybe even a day later. So I think that's where we've tried to take this risk-based approach. What is happening with the patient at that time? Are they incredibly sick? The IMDRF has kind of the risk categorization. The FDA has kind of the ability. We've tried to mimic that in our approach as well by partnering with our School of Medicine, our AI health group, as well as an ethicist, we try to understand and think, how close to the patient are you? How sick are they at the time? How time sensitive is that decision? The farther you get away, so if we're talking about diagnostics therapeutics versus I might change my schedule, or it may be something like I may do a no-show kind of thing versus, okay, this is going to be me summarizing your documentation of your chart. So me as the specialist can get something back and not have to look through 500 pages versus then we start getting further and further and further and further away from the patient. I think we've tried to take a risk-based approach as the closer you are to the patient, the more scrutiny is required. That's how it, and that's not always perfect, particularly as we talk about different use cases in the changing model of care.
Yeah. So, at Duke, you're in a highly academic medical center, so you have trainees, so you have medical students, residents, fellows, and so forth. And the AI stuff is going to bleed into clinical care in front of and with trainees. Do you feel like I guess my question is going to be more around, do you feel like we lose anything, or whatever, we're going to lose anything important with how quickly AI is changing healthcare? And does that mean that should affect how much AI you let enter into the training experience of a medical trainee?
I don't think you lose anything by getting new tools that might help patients. So I'm old enough to know that a lot of some of the people who trained me would tell me, why do you need a CAT scan? Use your physical exam. Why do you need to get the ultrasound of your heart? Use the physical, listen. But these are tools that can be able to help with people. So, and this is the direction we're going. Most other industries have implemented today AI technology to improve their processes. Do I think this is a panacea that's going to solve all of our problems? Absolutely not. A lot of the problems in healthcare are not going to be fixed by AI, but they certainly can provide some guidance and help. Now, with trainees particularly, this is the world they're going to train in. Do you want your doctor not to have any experience with working in this space when they go off and get the real job? I don't think so. AI is a tool. At the end of the day, they've got an array of tools that they have to understand. They've got diagnostics, labs, imaging, biopsies, things like that. All of these have downsides. All of these have A, risk, and B, they may not get you the answer, or they may lead you down a wrong path. But we try to teach them to understand, hey, if your suspicion is high enough for this disease and you've got one test that comes back that says it's not there, don't just go by the one test. You have to think. That paradigm to me can still be applied in AI. It's about how you train. It's about understanding the data that it was built on. We have a wonderful group called the Duke Institute of Health Innovation that created this idea of a nutrition label. The idea of the nutrition label, when you look at it, is to at least get a cursory understanding of this is what it was designed to do. A tool is designed to do a specific thing. You can use tools in other scenarios, but realize it was never designed for them. So you have to understand what it was designed for, how it was designed, the data it was used, and the outcome it was trained to do. Because if you're not following those, you have to understand that there were risks to that. And so I think, to me, that's where we need to start thinking about how do we train our staff and our house staff officers in this new world where AI technologies are going to be more rampant, they're going to be more common, and how do you take that into consideration in your clinical reasoning?
Analogy comes to mind is so right now, vast majority of cars are still not self-driving. So if you're going to get your driver's license and you're going to take a road test, you're not going to be self-driving on the road test, right? But you could imagine that over time, there are going to be at least some maybe co-pilot, maybe not self-driving, but additional AI-enabled features in cars and whatnot. And even if you still wanted someone doing a road test, you want to know, can they actually use all the tools at their disposal? Because that's what everyone's going to use at some point. And so to your point, it's what's the point of training them in a way that won't be how they actually practice once they're actually, certified and whatnot? So that makes a ton of sense.
Yeah. And actually, Armando, just to unpack the nutrition labels part a little bit, just because I think that's such a novel idea that I hadn't heard before. Is this on actual AI models that are internal to Duke? And you're saying this one has been trained on XYZ data and it's for clinicians in the organization and everyone in the organization to understand how they could use the models? Or are you talking more broadly to tools itself or built out workflows with the AI models?
Predominantly AI models. So our Duke Institute of Health Innovation, when they develop a model, they create a nutrition label for it, which makes it easier for people to grasp what it was designed for. They may, model themselves have a certain amount of, depending on the type of model it is, transparency can be an issue. So this is our attempt to try to explain what was it originally designed to do. Are you using it off-label, for example? Might be another akin metaphor we use in healthcare a lot. We use things off-label all the time, but it's understanding what was it designed for to begin with. Where does it shine, I guess? And that type of information is useful for clinicians because that if I'm not using it in that paradigm, there's a layer of caution I should understand, and to take a second and be like, okay, this was not what it was designed for. This is not it, but I can use it, but I need to understand that I'm using it that way.
Right. Very cool. So you've came up with being called the Pareto principle of healthcare AI, which you said something like a successful algorithm is 20% algorithm and 80% human factors. Can you unpack that idea for this? Like, what does that mean? And what's a real life example in healthcare that you've encountered that really well illustrates this?
So everybody gets excited about the algorithm, right? Everybody gets excited about the thing you create, the device, the model. Everybody gets excited about it. And they should. It's awesome. It's cool. We're using new technology. We're pushing the envelope. And I go back to my metaphor of a tool. How good is a screwdriver without the person understanding how to use it and how to actually, when to use it? You can't use a screwdriver for everything. You can't use a hammer for everything. These tools were specifically designed to be done in specific scenarios. You would have a very hard time using a hammer when you're supposed to use, a Phillips screwdriver. It just doesn't work. So what I tell people is, and we've had experiences we've published on some of our early experiences on early warning scores, for example, where the model itself actually wasn't bad. It was actually a reasonable model, but we deployed it. We deployed it in a way that we did not set up our folks for success. So the human factors part, the behavioral economics. As me as a clinician, if you pop up a widget saying, hey, something's going on with this patient, it's AI, the idea is that a lot of smart people went in to develop that model. It's been verified. So I should listen to it. But how do you get me to listen to it? How do you put it into a workflow where I'm not just annoying you, just put up an alert, but I'm trying to do something else? Or I don't even know what this is about, so I'm just going to X out of it. Or I don't trust it. I don't believe it. So that human factors, that adoption, that understanding, that behavioral economics of putting me in a position where I am willing to listen to it and take that into my reasoning, to me is so important, because great tools can be built, but if you do not have it in the appropriate place in a workflow that is fast, that is complex, that is moving quickly, it will not work no matter how good it is. So to me, the rate limiting step is not algorithm development to an extent. It's a lot of it, when I'm thinking about it in a project, it's really the human factor. That's really what is going on with that workflow. Have you mapped it out? Do you really know what the problem is? Do you understand where this piece of information needs to be placed to make a change in the decision? Because you obviously think that this is going to work. So help me find where it should go. And then how do we scale that? How do we maintain that? How do we make sure it's going to work at 2 a.m. when something might go wrong? That's all human factors. So to me, I think that's such an important part to illustrate our early warning score kind of concept. We deployed a model that we put to everybody, essentially. We deployed an alert that would go to everybody. It was firing all the time. It didn't work in the way we wanted it to because we didn't think about the human factors. And we revamped it. And the model was not really designed to what we were supposed to be looking for. And our innovation group created a model that was very targeted to the disease we were going after. And we created a team that was specifically trained around understanding that model, understanding the risks and benefits, and then they would receive the alert and they would be up to them to go out and speak with our clinicians with regards to, hey, there's an alert going on. I'm augmenting what I learned from this model because I read the chart. Here are my thoughts to you. So it acted a little bit of an augmentation to consultants. And so we took that human factors part in there as well.
So I guess, do you find there's a common kind of story where, let's say, a clinician / researcher comes up with this amazing idea for how a model could help solve a certain problem. So they build it and it works, it's fairly accurate. But then to your point, the next step is, wait, how do I actually get this to be used in the clinical environment. It's almost like step one is, wait, I have to actually convince and sell the model to the other clinicians, because if they don't even see value in this model, then I can't even get to step two, which is how do I actually make it work in the clinical workflow? And it feels like sometimes we focus so much on the model and the brilliant idea that we forget, wait, there's a whole implementation step here that may not actually ever work, actually.
You're standing up software, essentially. This is software development, and there are principles in software development. And one of the first things that I would even argue, even before that, is an assessment of the problem. What is the problem you're trying to solve? Because AI, it's fantastic. It's great. I love it. It can definitely work. But I have seen also AI technology used in a scenario where you probably could have done something with less work, less resources, or it's not going to work because of XYZ reason, because of the workflow or the data flows, things like that. And so I think, to me, it's really cementing the problem you're attempting to solve and not having a technology solution looking for that problem.
Like, the one it reminds me of is, so when we think about most like remote monitoring that happens with patients right now, the triggers that are used to alert a clinician about a patient at risk are often very basic. It's like, oh, like now they're febrile, or their pain's a 10 out of 10, or certain biometrics are, outside certain normal ranges. And folks are used to responding based on those very basic rules, if you want to call them that. Even though everyone talks about like, oh, wow, like, with all the data we have, we could build more accurate risk prediction models that could predict the probability of mortality the next 7 days and all these things. But then when you take those more comprehensive insights back to the clinical team and you ask them, hey, like, how do you want to interact with those predictive insights? Often they'll say, like, I don't really know what to do with that, but I know what to do if they're febrile. So can you just tell me if they're febrile or not? You know what I mean? And so as someone who's not in healthcare, you don't realize, oh, wait, like I can't just give you an insight. There has to be a clear directive or a protocol. Otherwise, that insight is just left hanging there. And it wasn't actually better than the less sophisticated workflow that was already in place.
In my training, I am trained to think about what is the differential of a fever. I'm not trained to be like, well, the risk model just fired. What am I supposed to do with it? I'm not trained to think that way. I've done packet as well. So I'm not surprised people would come back to you and say, well, can you just give me the more simplistic thing? Because I know what to do with that.
It's actionable.
Yeah. Exactly.
Right. Yeah. So I'm curious, Armando, what are some of the most common misconceptions that you hear from your clinicians about AI? Do they think it's just going to solve everything, or like, what are you hearing?
I don't think I think most people nowadays don't think it's going to solve everything. I think a lot of people, you kind of get one shot attempts. And I think that's probably a misconception a lot of clinicians, that will be pejorative to my kind. When it's wrong the first time, I'm like, well, this doesn't work. It's done. In reality, when you look at the statistic, of course it's not going to be. If you're talking about a rare event such as decompensation, it's not going to be right most of the time. That's not the point of the tool. So I think, to me, that's also a misconception, that it's always like, it's got to be right every single time. And not realizing that if you look across a lot of our diagnostics, we see abnormal stuff pop up all the time. We just know how to interpret and say, well, this matters, this doesn't. So I think, to me, that's probably a very common misconception of, I see it once, it doesn't work once, I'm done. I'm not going to look at this, and then I've lost. And to me, that's a little bit of a training conception of understanding of like, well, how does AI technology work? I think the other misconception is that it's easy and that it's quick and you can do this in a second. And that I think people just see the tip of the iceberg of just see the outcome, and they don't realize that the iceberg underneath the water is monstrous. There are lots of people who need to be involved with this to make this thing work. Because you're not just talking about, you're talking about the predictive model lifecycle, but you're also talking about software development and the package of technical infrastructure, then the data science part. So I think people also get in the misconception like, oh, this is easy, you spin it up, make it quick. I give you here. There's this thing that I created, in R or whatever, deploy it, make this happen. So those are two kind of the misconceptions that I see quite often.
Yeah, it kind of reminds me of even like now with like ChatGPT having exploded the last couple of years, like almost everyone is at least familiar with generative and LLMs, but I don't think most people still realize that it's actually just a prediction algorithm, right? It's not like it's actually querying a database and finding an answer. It's like, no, it's actually just predicting the next word based on, studying a bunch of previous data. And so people get confused, like, well, why is it hallucinating? Like, why is it great in some things but not others? It's like, okay, well, you have to learn how it works. And I don't know if we'll actually get there, because let's be honest, for most technology and data we're doing right now, probably most of your clinicians don't know the nuts and bolts of it. You could argue that's actually your job, I guess, to be the one dealing with that.
It probably is my job.
So I don't know how much like AI literacy we can expect from our colleagues, because that they may not be their core job to be AI literate. Or maybe you could argue, well, actually, everyone should be AI literate to some extent, because it's going to transform so many things we do. I actually don't know. There's probably some basic AI literacy you want clinicians to have, and I guess over the next couple of years, we'll kind of figure that out, and it's going to be incorporated in the curriculum and your training and your onboarding of the staff. It's probably still in flux, I imagine, even at Duke.
We have some educations that we are attempting to do it within our department and our organization. I do believe we're going to need to have some form of AI literacy. Like I said, when it comes to the CT scanner, the MRI, very specific type of staining when they do on biopsies and stuff, do I understand the technical components that have occurred to those cells or in the machine, the electrons, the radiation, all those things like that? I'm not trained as a radiologist or radiation oncologist, pathologist to understand those parts of it, but I understand when it's the right time to use that tool, and I'm trained to understand its output. I'm trained to understand when to be skeptical, when to, say this is important, I need this information, or it's non-diagnostic, I need to go down the, I understand that in my framework of training. I think people need to take that same approach when it comes to AI tools. We may not understand exactly every single little thing that happens within the AI tool itself, but we need to understand, particularly around the inputs and the outputs part of it, and how does it affect my clinical reasoning, and how do we train people to understand?
Yeah. So I'm curious, Armando, you brought up the idea of having multidisciplinary teams. Building AI data scientists are so important, and then you have your clinicians, and how do you communicate the different changes to each group? So I'm curious around governance with AI. Could you tell us a little bit about, I believe it's called the ABCDS at Duke?
Yep. So algorithm-based clinical decision support. I think this is a wonderful example of multidisciplinary approach. So in medical school, I learned about the Krebs cycle. I learned anatomy. I learned, respiratory systems. I understood in the cardiopulmonary and things like that. I was never trained in data science. This type of ethics, when it came to, data and things like that, it wasn't part of my training. So the expectation that only clinicians are going to be able to create governance around something as complicated as AI, I think this is where you have to expand out and to really broaden the team who have different training. So at Duke, what we've done is we have a wonderful partnership with the School of Medicine and our AI health group. And what we did is we came together and said, we want to be able to innovate. We want to be able to do this safely. We want to improve trust. We want to be able to allow innovators to come and bring AI tools that we think might help patients. And so what we did is we created this multidisciplinary team where we have clinicians, we have people in clinical informatics who understand some of the data components to this. We have operational leaders. We have an ethicist. We have data scientists. We have members of our legal team and representation there, because we know this is a fast-moving space. The FDA has come out and said certain things, the FTC, all these people have said different things, because this is becoming a more and more regulated space, and we need to maintain and make sure we're in compliance. All of these people come together to talk about the different tools that are coming forward, evaluating each tool and saying, okay, when we look at this, these are the things we need to make sure are in place. Have you thought about this? What about a monitoring plan? Have you looked at this population? We look at the different policy documents that come out and say, okay, this is important. We need to adjust our approach to the way we govern this. And this is something which I love about being in an academic center as well as Duke, is that we have the ability to do this. And what Duke has attempted to do through various organizations is try to broaden and publish this type of information for larger groups to understand that may not be an academic medical center as well, because there's lots of institutions that want to use AI, and our hope is that we can create blueprints and standard products, standard information to be able to help the community.
Yeah, that's wonderful. So Armando, just looking at the time, I want to be mindful of your time with us. So we're going to flip over to the Fast 5 lightning round. So this is just 5 questions to get to know you a bit better. The first question we have is, what is your favorite book or book you've gifted the most?
Oh, okay. So I am gifted many books and everything. I feel like I should be doing that more and everything. I'm a big history nerd. And I think I'll talk about the more recent book that I read was actually I listen to Audible more than anything when I read. And so Endurance, Ernest Shackleton's was the one that I recently read, which is a really fascinating book about just his journey and the whole shipwreck and trying to these type of Northwest Passages kind of stuff. So to me, that was one of my more recent favorite books.
Yeah, awesome. Question 2, who is a person, either dead or alive, who you'd love to meet?
So being a big history nerd, I have to break up certain parts of the timeline here to be able to say. So and this is actually a true statement that I'll say, if I wasn't a doctor, I'd be a history professor. Right. One of my favorite time periods is the late antiquity time period. So I actually would love to have met Thomas Becket. He was an archbishop, a chancellor that was actually murdered by Henry II in the 12th century. And it was a great example of like church versus state kind of stuff. And so I recently read one of the books about him and everything. And I just found it absolutely fascinating. Would love to meet him and just hear about his life in that time period.
Yeah, awesome. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Oof. I do not want to read people's minds. Those are too private. There are things I never want to learn about people I know. So I'll pick super speed. I think that'd actually be pretty cool because you can actually go and visit different places and go pretty quickly and just go there and come back. So I'll
just run there.
Yeah.
Yeah. I also want to be fast when I run. So that's actually very appealing to me.
Oh, that's awesome. Question 4, what is something in healthcare you believe that others might find insane?
I can pick quite a few. I will say, the expectation that you're in charge of a bunch of people and you can work for 24 hours or we have rules in aviation, for example. You can't be flying a plane with so many amount of people on there. That to me is still a little bit of insanity. Obviously, other people will find it as an insanity. You can be up for 24 hours and you are going to be mentally crisp and perfect and everything. So I think most people still would find that insane.
Yeah, no, definitely. Last question we have, what is the last film or TV show you saw and what did you think of it?
Oh my God. Okay. The last film, I did actually watch was actually Mrs. Doubtfire. And this is,
nice.
Okay. So you guys are know what Mrs. Doubtfire, because my children are 10 years old and 7 years old. And my wife and I are trying to get them to watch some of the movies that we used to watch. We just made them watch The Sandlot. And so we're like, we're going to watch Mrs. Doubtfire and stuff. And I mean, it's Robin Williams. It's a class, rest in peace. He was one of the best, comedians of the time period. And it's just a funny film and everything that I wanted my kids to experience as well. Similarly, when I was, younger.
Yeah. 100%.
It's funny. If any medical students or residents are listening to this, they have no idea what Mrs. Doubtfire is.
I did a quote from The Sandlot, and my kids have no idea until I'm like, we're going to watch this show. You can't not know these types of quotes.
I love that. That's amazing. Well, thank you, Armando. That's a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter @SeamlessMD. And if you like the podcast and you want to learn more, visit www.seamless.md. Armando, again, Dr. Bedoya, thank you so much for spending the hour with us, sharing so much wisdom with us and our audience. And I really appreciate you taking the time.
Thank you both. It was great.